Today we will be discussing some cardiovascular anatomy and physiology. We'll start with anatomy in the cardiovascular anatomy and physiology section. This section is particularly high yield because a lot of concepts will be tested on your exam. Test question writers love to incorporate some of the fundamentals, particularly physics, on your exam. This is a super high yield topic because of how important it is in understanding the localization of myocardial infarctions. We will talk about myocardial infarctions more in the cardiovascular pathology section, but for now, let's review the course in which region the coronary arteries supply. So the coronary arteries originate from the root of the aorta. So this is our aorta, and it will give rise to the ascending aorta going this way. And this is just above the aortic valve cusps, which will be sitting right here. So the right coronary artery arises from the right part of the aortic root, and the left main coronary artery arises from the left section of the aortic root. So let's examine the left side first. The left main coronary artery passes between the pulmonary trunk and the left atrium. The left anterior descending will pass in between the pulmonary trunk and the left atrium and start traveling in the atrioventricular groove. So it travels in the atrioventricular groove, which is not shown on your diagram, but it is delineated by those two lines that I just drew. So again, what two arteries will the left coronary artery divide into? It will divide into the left circumflex coronary and the left anterior descending coronary. So this is a very quick, easy concept that's in our mind. Now, thank goodness they named these this way because they tell you exactly where they're going to travel. Now, as we trace the left anterior descending, it is descending along the anterior surface of the epicardium, within the anterior interventricular groove toward the apex. And as we all know, the apex is the most inferior aspect of the heart, facing the anterior chest wall. So you must remember what I'm about to say, no matter if you're daydreaming over there. So focus in with me. The left anterior descending gives off septal branches, just like this, to supply the anterior 2/3 of the interventricular septum. And it also gives off diagonal branches to supply the anterior surface of the left ventricle. So let's write this. Septal branches, anterior 2/3 of the interventricular septum. And again, septal branches, septum, and the diagonal branches of the left anterior descending are going to supply what? The anterior surface of the left ventricle. And this should all make sense because this is where this artery is coursing. So again, if we examine it in a cross section of the heart, with this being our right ventricle and this being our left ventricle, this is our interventricular septum. The septal branches will be supplying the anterior 2/3, and then the diagonal branches of the left anterior descending will be supplying the anterior aspect of the left ventricle. This is incredibly high yield. Let's repeat it one more time. The left anterior descending, which is a branch of the left main coronary artery, descends in the atrioventricular groove, gives off septal branches to supply the anterior 2/3 of the interventricular septum, here in our diagram. Now what about those diagonal branches? The diagonal branches supply the anterior surface of the left ventricle, denoted as here in your cross section. A good way to remember this, besides memorization, is to understand what is directly under the left anterior descending. Now guess what that is. Directly under the left anterior descending is the interventricular septum. This should make a lot of sense to you because the interventricular groove of the pericardium, which our anterior descending artery is traveling in, is sitting directly above the interventricular septum of the myocardium. Remember, everything in the body is divided geographically in a way that makes sense. If the artery is coursing in the pericardium above the location of the myocardium that it supplies blood to, this is very beneficial and efficient. So remember, LAD, septal branches, anterior 2/3 of the interventricular septum as it courses towards the apex. This is a crucial anatomical point to remember because any compromised blood flow to the LAD will decrease blood supply to the interventricular septum and the anterior left ventricle. This is important when you think about infarctions. An infarcted interventricular septum. So again, if we infarct the anterior 2/3 of the interventricular septum because we have decreased blood supply to the left anterior descending with an atherosclerotic lesion, we will increase our risk for rupture and creation of a ventricular septal defect because the infarcted muscle will leave non-viable myocardium. which will be very prone to rupture, especially when macrophages are removing all of the necrotic debris. Alright, so now what about this circumflex? First of all, why is it called the circumflex? Well, as you can see, it winds around, circumflexing around towards the posterior surface. The circumflex gives off large marginal branches that supply the lateral and posterior wall of the ventricle. So let's draw our cross-section again. Remember, we said this is the anterior 2/3 is by the LAD, and so is the anterior surface of the left ventricle. Now our left circumflex circumflexes towards the posterior wall, and it will supply the lateral and the posterior surface of the left ventricle. So let's summarize quickly. LAD supplies the anterior 2/3 of the interventricular septum, the anterior papillary muscle, and the anterior surface of the left ventricle. The left circumflex supplies the lateral and posterior wall of the ventricle because it gives off a left large marginal branch that supplies the left margin or left lateral wall of the left ventricle, and the posterior wall of the left ventricle is supplied by this segment of the left circumflex that is winding around posteriorly. Now what about the right coronary artery? It delivers blood to the right ventricle via some acute marginal branches, as we have listed here. And in a majority, and by majority I mean 85% of the population, the right coronary artery will give rise to the posterior descending artery. As you can see here, it's winding around, and then we have our posterior descending or interventricular artery. So remember, there will always be anatomical variance in every organ system, which is rather unfortunate because it is more we have to remember. So the other two situations are that the posterior descending artery arises from the left circumflex, and that will occur 8% of the time. Or in the other situation is that the posterior descending artery arises from both the left circumflex and the right coronary artery, and that occurs in 7% of the population. So don't worry about memorizing these percentages, just remember that in a large portion of the population, the posterior descending artery comes from the right coronary artery. And if it's not coming from the right coronary artery, then you better check the left circumflex because it arises from there 8% of the time. So if the left anterior descending artery, which we previously discussed, supplied to the anterior 2/3 of the interventricular septum, again, anterior 2/3, which artery do you think supplies the remaining 1/3, or the posterior 1/3 of the interventricular septum? So go ahead and send an email to your cardiology module directors and tell them, hey, it's so simple, why didn't you ever just tell me that the posterior descending artery is also called the posterior interventricular artery, because it supplies the posterior 1/3 of the interventricular septum and posterior walls of both ventricles. Posterior descending artery essentially comes from the infero-posterior or inferior and posterior part of the heart to the apex, where it meets its longtime pen pal, the left anterior descending artery. So we can summarize and say that the right coronary artery supplies blood to the inferior and posterior ventricular walls via the posterior descending or interventricular artery. Now let's discuss other important high-yield cardiac anatomy related to the right coronary artery. This might actually be a question on your exam, so attention is critical here. Focus in with me. Can you tell me which artery splits off right before the right coronary artery branches to become the posterior descending artery? It's not the acute marginal artery, which supplies the right ventricle. You actually have small branches of the right coronary artery termed the SA node and AV nodal arteries. If you told me AV nodal artery, then you probably can also tell me why this is so important to know. Because the right coronary artery normally supplies the AV and SA nodes via the AV nodal and SA nodal arteries, occlusions of the right coronary artery can lead to fatal arrhythmias. And you knock these out, equals dead. I mean, that's not an absolute. So if you think about it, if you knock out the SA and AV node, the cells that set the intrinsic automaticity of our myocardial depolarizations, you will have an increased propensity for ectopic beats, which means that other cells of the conduction system, particularly in the Purkinje or the ventricles, will have to set the pacemaker baseline depolarizations. And we have discussed how this can predispose us to fatal arrhythmias because there will be desynchronization of depolarizations of the myocardium. We will get much more further in depth in the cardiovascular pathology section, so don't worry. So two other important pieces of information listed in your first aid book are also critically important here. The coronary arteries travel in the epicardium. Remember, it's three layers: the epicardium, the myocardium, and then the endocardium. What is important to also remember here is that the endocardium is just the endothelial cell layer that's actually lining the ventricular chamber. The cells in the endocardium receive oxygen and nutrients from the blood that is within the ventricular chamber. So myocardial infarcts rarely ever affect the endocardium. The cell layer that sits directly below the endocardium, which we would term the subendocardium, is the most prone for myocardial infarctions. Now the reason for this is that the coronary arteries travel in the epicardium, and they send perforating branches down through the last layer of that epicardium, through the myocardium, and down all the way to the subendocardium. So what do you think is going to happen to these perforators when the myocardium is contracting? As you can see, they're traveling through this contractile element of the heart. Well, when the myocardium contracts, these will be crimped down on, and it will not be very conducive to perfusion. So do you think that these perforators can provide blood to the subendocardial layer at all when the heart is contracting? Absolutely not. Perfusion of the coronary arteries and their distal perforating branches has to occur at a time when the heart is relaxed. We have a fancy medical term for this. It is called diastole. The reason that we also perfuse the coronary arteries in diastole is related to the location of the aortic valve leaflets in relation to the openings or ostium where you perfuse the coronary arteries. As you can see here again in this diagram, the aorta is ejecting blood obviously into the systemic circulation, and to do so we must open our aortic valve leaflets. The openings to the coronary arteries are sitting here at the root of the aorta. In systole, the aortic valve leaflets fly open and they block the ability of blood to flow into these coronary artery openings or ostium. That is why we must wait until we reach diastole. So it must go from systole to diastole when there is a decreased ejection because we have completed systole and the valve leaflets are shut so that these openings are now able to receive blood. So perfusion of the coronary arteries and their distal perforating branches has to occur during diastole. The last high yield fact, which I definitely remember was on my step 1 exam, is the relationship of the most posterior part of the heart with an important nerve that we've already mentioned in the embryology section. Remember, it wraps under the ligamentum arteriosum. If you have this concept on your exam, you will probably be presented with a question that goes something like this. You have a 54-year-old white female with a history of severe sequelae. Sequelae just means that you have some bad residual morbidities associated with some disease that you had when you were younger, or at any point in time. So, 54-year-old white female, history of severe sequelae after a bacterial infection as a child, has a transesophageal echocardiogram, which is when they stick the sonogram element in the esophagus detector, and this is done because her cardiologist was following her for a systolic murmur heard best in the apex. So we had a systolic murmur here, when the cardiologist grew concerned when the patient reported a 2-month history of hoarseness. This is new onset hoarseness. What results would the transesophageal echocardiogram most likely indicate? So this is a super loaded question full of many concepts the examiners could come after you with. But let's focus on the cardiology element here. So the sequelae from the severe bacterial infection should make you think rheumatic fever, considering the next sentence mentions mitral regurgitation. Remember, we had a systolic murmur that was heard best in the apex in a 54-year-old white female with a history of some sort of bacterial infection that now is causing her to be followed by a cardiologist. You should be cued off towards mitral regurgitation due to rheumatic fever. So that means that we have regurgitation of blood from the left ventricle into the left atrium across that incompetent mitral valve. We're essentially pushing a bunch of volume over and over and over again into the left atrium. Over time, this causes a balloon-like dilatation of that left atrium, because that is the way that the heart compensates for an increase in volume. It compensates differently for an increase in pressure. So the regurgitation of blood into the left atrium across the incompetent mitral valve has caused a compensatory hypertrophy and dilatation. Eventually, the dilatation of this left atrium will compress a nerve that's running right here near it. What nerve is that? The left atrium will be compressing the left recurrent laryngeal nerve, and that nerve is responsible for innervating all of the intrinsic muscles of the larynx, which is why she's been presenting with a 2-month history of hoarseness. Alright, great, you guys dominated that. Let's go ahead and move on to some physiology. In a quick review, this is the area that is supplied by the left anterior descending. Remember, it comes down here in the atrioventricular groove and supplies the anterior 2/3 of the intraventricular septum and the most anterior aspect of the left ventricle. The left marginal artery comes off the left circumflex, and this supplies the lateral element of the left ventricle, while the left circumflex supplies the posterior element of the left ventricle. The right coronary artery comes down and gives off the acute marginal branches that supply the right ventricle, and then it gives off the posterior descending artery, which supplies the posterior 1/3 of the interventricular septum and the posterior aspect of the right ventricle.